So while at the symposium, we are a collective force united by our desire to enhance the quality of care for veterans, and afterwards we become individual champions for continued resuscitation, education improvement within our own VA facilities. As many, if not all of us, understand the gravity of a cardiac event, and it cannot be understated. They not only affect the patient, but their family, their friends, and us, their caregivers. It's in these life or death moments that our preparation, our knowledge, and our dedication to gold standard of care is put to the test. I'm excited to introduce our next plenary session, where we will have the opportunity to hear from Dr. Camilla Sassoon, one of the foremost experts in the field of cardiovascular care, who has made going above and beyond for her patients central to her work. Dr. Sassoon is a Vice President for Healthcare Business Solutions at the American Heart Association, with an MD from the University of Illinois at Chicago School of Medicine, an emergency medicine residency at Emory University, and a Master of Science in Health and Health Services Research from the University of Michigan, and a PhD in Health Services Research from the Colorado School of Public Health. It's safe to say that she knows her stuff, and we could learn a couple of things from her. In addition to her illustrious academic and research background, Dr. Sassoon works clinically as an emergency physician for the Colorado Permanente Medical Group and maintains appointments in the Colorado School of Public Health. And with all this on her plate, she also serves within the VA San Diego as practices clinically, and serves as the special advisory to the VHA Medical Advisory Panel and leads VA's Emergency Department Opioid Safety Initiative. Her medical prowess is evident and makes her the perfect person to deliver the first of our 3 plenary sessions. Her commitment to alleviating health disparities and adverse outcomes by bringing diverse stakeholders together could fill a textbook. But seeing that we don't have time to read that book, I'd like to be the first in line to buy it and have her discuss the International Liaisons Committee on Resuscitations, or ILCOR's 10 steps to improve in-hospital cardiac arrest outcomes and quality of care. I'm on top of the world. I'm on top of the world. Been waiting on this for a while now. Paying my dues to the dirt. I've been waiting to slide the whole thing.
Right. Well, thank you. First of all, I want Lisa's playlist, so I'm going to put that out there. Thank you. So excited to be here. As Lisa mentioned, I work at the VA San Diego, clinically in the emergency department, so I've been able to see the RQI program in action with our veterans when we've had resuscitations happen in the emergency department. And then I also work nationally working on opioid safety and just starting up an addiction hotline. So we actually have one at Prescott, at the Prescott VA as well. So just want to say thank you again for the opportunity to chat with you guys. And this is going to be a brief presentation, but I want to be able to have lots of time for questions as well. So as an introduction, as many of you guys know, this is the adult in-hospital cardiac arrest chain of survival. And really, many of you guys are living and breathing this every day, from early recognition, making sure that everyone is prepared to know what to do, providing that high-quality CPR, defibrillation, post-cardiac arrest care, and then, of course, thinking about recovery. And the Heart Association, I think, is really hopefully starting to build even more resources around these, and I think you should see those coming up soon. We also will have new CPR guidelines coming up in 2025 as well, so we hope that you guys are also excited about those. We've been working on them since literally the day after we published in 2020. So it's a work in progress for sure. And we'll also have our first aid guidelines, which may impact some of the work that you guys are doing as well, that will be coming out in 2024 as well. So coming soon. So I'm here today just to talk about the 10 steps to improve in-hospital cardiac arrest, and this is on behalf of the ILCOR writing group. So ILCOR, as you guys know, is the International Liaison Committee on Resuscitation. So it's about 100 global experts that come together literally every week to talk about the evidence base for cardiac arrest and resuscitation. They're based off of specific task forces that they work in. We actually created a subgroup of that group of global volunteers specifically to work on this project. So our charge was that IHCA is a high-risk event among hospitalized patients, as we all know, and we know that there's a huge variation in outcomes. So we launched the initiative to identify the 10 steps This is, I think, kind of going along with the Code Blue Clue, 10 theme that we have going on today. So the 10 steps that institutions can take to improve care of in-hospital cardiac arrest. The idea was that we wanted these goals to be pragmatic, actionable, and holistic. We did not conduct a formal literature review or grade evidence independently. We really used this as a Delphi process to try to come up with what we thought, based on 100 folks in the room, plus all of our different geographic locations. So we had to focus on lower resource settings. We wanted to really kind of bring up everyone's ideas and then really hopefully collate them down to 10 steps. So this is based off of the OHCA 10 steps. I'm not sure if you guys are familiar with this, but this is through the Resuscitation Academy and the Global Resuscitation Academy. They've done a great job of really trying to hone in on how do you improve out-of-hospital cardiac arrest. And so we use that as our model to create the in-hospital version. So this is just a schematic that looks at the risk standardized hospital survival rate for cardiac arrest and just how much variation, as you can see, there is between facilities. And this is taken from Get With The Guidelines resuscitation data. What we know is that with that huge variation, there are some common themes that we know can make a huge difference. And so that was really our charge as the scope of work for our group. Develop consensus statement on key components hospitals can use to optimize clinical outcomes in adult and children patients with IHCA. Interestingly enough, our initial charge was only for adults, but because we had such a great group of volunteers from all over the world, which included adult and pediatric specialists, we ended up getting enough consensus to say that this could work for both adults and pediatrics as well. So that was actually something that happened later in the process. We envisioned that these strategies could be implemented in different country settings. As I mentioned, we had quite a few folks from lower resource settings and with different resources, because we know all of these 10 steps have to be able to be tailored to the specific location in which they're being utilized. So our writing group was based off of ILCOR, AHA, IHCA leadership, and then we had 3 co-chairs, Dr. Tino Grief, Dr. Paul Chan, Dr. Brahmaju Nalamathu, who many of you guys may know as well. And then we were divided into 3 main groups: pre-arrest, intra-arrest, and post-arrest. And then between that actually went into 4 subgroups as well, which focused on teams, systems, education and training, and ethics. And then we had a number of meetings preparing to go to Brisbane, Australia, where we talked about just really kind of, again, honing in on what we thought would be the most important steps. We then went to Brisbane and had an in-person meeting where there was large group presentations, some small breakout groups as well, a cardiac arrest survivor story. So we had a cardiac arrest survivor who actually is a physician, an AHA volunteer who served on the writing group. And then we went through a iterative process of trying to narrow down to 10 steps. So our results, and this was actually published in Circulation and Resuscitation in November of 2023. So you guys can have access to that paper as well. This is just the infographic that looks at the kind of overall 10 steps to improve cardiac arrest, and then this is really our central figure for the actual paper as well. So we'll start first with our first section here, plan and prepare. So build and support governance and infrastructure, collect data to measure and improve, and implement effective education and training. So again, I would say that many of you guys, as we talk about building and supporting governance and infrastructure for a resuscitation program, the VA is really ahead of many other healthcare systems in the country and even globally, because all of you guys are not only just active leaders in your facilities, but you have the opportunity to attend things like the Ready Symposium, where you can actually network and you can have all of these great discussions. So again, this is what makes me proud to work at the VA for many reasons. So I would say that you guys are already doing step number 1, just by the fact that you guys are here and you guys are doing amazing work. So within that first step, create a governance structure with administrative leadership to advance resuscitation excellence, empower local operational champions like yourselves, and ensure a robust quality improvement program. Part of that is also then the second step, which was to collect data to measure and improve resuscitation processes and outcomes. And this becomes really important as we start thinking about, if you don't measure it, right, you can't improve. And that's really one of the big things I think that's central to the VA, is that we have all of these great data systems that allow us to track how we're doing. And not in a punishment type of way, but really just to be able to benchmark and say, look, this is where we are, and this is where we want to be, and this is where we know others have done it successfully, so how do we learn from each other? And I think that's a really key piece of that learning community that you guys are all a part of. So with that, step 2 was really to use data to assess education, training, performance, and outcomes across the continuum of resuscitation care, and to devise and evaluate the impact of quality improvement efforts to ensure their sustainability. Consider participating in resuscitation registries to enable benchmarking and contribute to knowledge transfer. So on the ILCOR website, where we have all of these 10 steps listed, we actually have the ability for folks to put in case studies or really highlight some of the work that they're doing in their own specific institutions. So we have, for example, Get With the Guidelines Resuscitation. This is a program sponsored through the Heart Association that has really been, I think, key in terms of helping us gather data on how resuscitation efforts are going. You guys have something similar within the VA in terms of your data collection around resuscitation as well. We have over 1 million records in Get With the Guidelines resuscitation, and we have about 550 actively participating hospitals that contribute data to this database. The thing that's nice about this is that we have reporting, we have benchmarking, and we have the ability to create, again, these learning communities, which, again, the VA has here through the Ready Symposium. So the next step for Plan and Prepare is to implement effective education and training for resuscitation. And I think this is an important piece. When we first created this step, we really wanted to focus in on creating and maintaining resuscitation education and training programs for resuscitation, which include standardized in-person resuscitation courses to practice psychomotor skills, low-dose, high-frequency in situ training, and then team-based training and simulations and debriefing to learn from resuscitation events. So one of the questions that I know has come up is really, what do we mean, or what did the writing group mean when we talk about standardized in-person resuscitation courses? So standardized in-person training, as we know, there's the 2-year option, right, to be able to go hold a class and then every 2 years have your recertification done. When we were talking about this specifically, we were actually really talking about the RQI experience. So what you guys are talking about and what you guys are doing every day in your facilities is what the writing group really wanted to highlight here. And this was not just the every 2-year model, I'm going to go take a class and I'm going to get my skills and I'm good to go, but really thinking about how low dose, high frequency can be incorporated, just like the VA has done, to make an impact, right? That muscle memory that Dr. Zhang had mentioned is so important. That ability to know that everybody has the same training, everyone is practicing that regularly. We know that resuscitations can be a relatively infrequent event, hopefully, in our institutions. And so just being able to have that sort of in-person, low-dose, high-frequency approach is really important. So that was really what we were talking about when we talked about this specific step. It was about standardized in-person training with that in-person psychomotor skills that are done every quarter, just like you guys are doing with RQI. And as you guys know, RQI obviously is really our key way within the Heart Association that we think is really the wave of the future, right? We have now millions of people who are going through the different training programs that we have, and RQI has been gaining momentum steadily since its inception. And the VA has really been one of the leaders in terms of both getting this started, but helping us to continue to iterate and to improve on it as well. So as you all know, 2010 was when the concept was initially created. 2011, we published research demonstrating the impact of a low-dose, high-frequency CPR quality improvement intervention. 2013, the iterative concepts were tested with pilot hospitals, and then in February 2015 is when we first launched RQI. 2018, in July, is when we kind of ramped up our working on it with our partner Laerdal. And then in the initial mission goal, we have what we're hoping to do is to be able to save an additional 50,000 lives per year by accelerating the adoption of RQI across healthcare systems. And then just as additional data, if you will, on different types of training disciplines that we do have, obviously we have BLS, ACLS, PALS, HeartCode, and a lot of these will be getting refreshes and redos coming up in 24 and 25. So something else to look forward to along with the CPR guidelines updating is that you'll have new content as well. And just to show you guys how AHA is currently training across the world, this actually shows a global map of where all of AHA's global footprint is. So we have about 2,600 training centers and 5,000 sites here in the US. We have 400,000 instructors, 6.3 million people that are trained per year in the Heart Association within the U.S. And then internationally, we're in 100-plus countries, 3,000 training centers and sites, about 30,000 instructors internationally, 2 million folks trained per year. Get with guidelines, certifications, and then we have about 200 partner societies and foundation partners that we're working with to get this resuscitation knowledge out to as well. And then AHA courses are also offered in 12 different languages as well. So now we'll kind of switch topics a little bit to go to the next part of our 10 steps, and that's around the idea of prevention. So the first one is to establish goals of treatment early and reassess often, and then to stop preventable in-hospital cardiac arrest. So this, I think, is an important one in terms of thinking about how the patient's journey does not start the minute that they get into the hospital. It actually starts before that, and that's why this is really a continuum of care. And so this is really talking about proactively and collaboratively engaging patients and their families in dialogue regarding their preferences for resuscitation in the context of their values, comorbidities, frailty, and family needs. Recognize that there are patients for whom resuscitation is unwanted or unlikely to result in an outcome that is acceptable to the patient. Ideally, goals of treatment conversations would start in the community and then be updated on admission and after any change in clinical condition. So this is one of our case studies that we have available on the ILCOR website, and this is actually through the United Kingdom. So some of our folks from the UK that have talked about some of the tools that they've built out. And again, these are all freely available on the website if you guys are interested to learn a little bit more about each of these case studies. So they've created the RESPECT tool, and I wonder how long it took them to come up with this acronym, because I know trying to come up with acronyms is not easy. So very in awe of the fact that they were able to do that. So the RESPECT stands for Recommendations for Emergency Care and Treatment. And it really creates a personalized recommendations for a person's clinical care and treatment in a future emergency in which they're unable to make or express choices. So these recommendations are created with conversations through the person, their families, their health and care professionals to establish a shared understanding of their diagnosis and prognosis, what matters to them and what is likely to be a benefit to them in terms of their care and treatment, including a recommendation about whether or not to attempt CPR. So if you guys have a moment to take a look at this, I think it's kind of an interesting tool. It has been now widely adopted throughout the UK as really a way in which people are standardizing these conversations and then making sure that they're in the hands of healthcare professionals when a resuscitation may or may not need to be started. Yeah. Yes. I'm not sure if we have our mics available yet. Sorry. I know we're gonna have mics too as well, but sorry, I heard a little bit of this. I think the VA, as you'd mentioned, right, has their own tool, STDI. Yeah. Yes. Okay. And you sound like you may have a British accent. Is that correct? So. Oh, from Africa. Okay, great. Well, I was going to say, I think, again, this is where actually the idea of the ILCOR 10 steps is to create that learning community. And I think being able to have that tool available on this website actually I think would be really helpful, just because, again, what we're trying to do is create templates and resources for folks so that they don't have to feel like they're starting from scratch. Do you want to say your comment again? That'd be great. Yeah.
Hello. LSTDR has gone through the whole VA system, so every patient that's in the VA system should be offered LSTDR, life-sustaining treatment decisions, in the outpatient clinics before they get to the hospital. So it's, I would say, even more advanced than what they've got in the UK.
Well, I think it's usually in the cover sheet demographics, right? Because I feel like it's in that first, in CPRS, that's where that information is located, right?
Yeah,
Usually.
and the cover of thing on the top right-hand side,
Yep.
there's a tab.
Yep. And I was going to say, I feel like in the emergency department, we look at those a lot just because, again, it becomes important, especially when we've got...
But we're one of the only healthcare systems in the country that does that, and they've been actively working on it. We're not up to scratch completely with every patient in the outpatient who has one or more organ failures should be given opportunity to fill out an LSTDR, which creates an order set as well that goes wherever the patient was, because our life-sustaining treatment disorders used to be specific to where the patient was, and then they were moved from one place to another, they would be dropped. Mm-hmm. So we've done a really good job on that. I just wanted to point that out, that it's even better than RESPECT.
I think that's really, really important to highlight. Go ahead. Yeah.
How do you get your
So I think the question was, how do you get your outpatient providers to do that? And I'm going to turn that over to you again.
Okay, so it's not just us.
So for the answer for those folks over there was that it's an ongoing process and it's a pain in the, yes.
Resuscitation committees are supposed to be looking at the rate. So your palliative care people in the hospital should be looking at the percentage of patients that have LSTDI who get CPRs in the hospital. That should be an active data, like you were talking about, data is very important. So you should be looking at your hospital, how many people with one organ failure or more have LSTDI who get into the hospital and then code with or without having seen palliative care. So that should be an active process in all the VAs.
And I will say, if others have ideas too, and we'll kind of open this up again, more conversations as well about how to get your CBOC providers and outpatient providers. I mean, if you think about, one organ failure, that's a lot of our veterans, right? I mean, who, if we think about the sheer number of veterans that we're serving every day. So this, I think, becomes an interesting process. And it's one that I think is probably something that you continually have to focus on, right? Because again, I think the value in the outpatient setting maybe isn't as realized as it is in the inpatient setting, because when we do see one of those in the inpatient side, it is a relief in many ways, right? So thank you for offering that. So stopping preventable in-hospital cardiac arrest was one of the key findings, again, and key steps for the ILCOR group as well. So having systems like early warning systems and teams like medical and rapid response teams, and I think we mentioned today the surgical emergency teams as well, in place to enable early prediction, identification, response to deteriorating patients, providing effective communication to ensure a clear plan and safe transition of care. I will be going to the surgical emergency treatment teams talk today, because I think that's something that's a novel thing within the VA that other healthcare institutions are not doing. And I think that's a really interesting idea, because we know that those surgical patients are going to look different, right? And they're going to have different things that you need to consider, especially for early warning systems and preventing in-hospital cardiac arrest. So here's another case study that we have based, that was actually given to us by our folks from the Brigham. And they have a preventing cardiac arrest in the ICU, clinical trigger and response systems. And so this is actually specifically taken from their case study. And these are really the 4 buckets that they're working from. So there's hypotension. So anyone who's got new hypotension, if you're adding a new vasopressor, or you have a significant increase in vasopressor dose, that will trigger their early warning system. Anyone with respiratory insufficiency, so if there's an increase in respiratory rate, a change in mental status, or escalating oxygen requirements, that also will trigger their rapid response team or their early warning system to go into effect. Agitation, anxiety, so if a patient becomes combative, starts pulling at or off their support therapies, if they're now requiring antipsychotics, anxiolytics, and those are not being effectively maintaining helping with their agitation. And then if there's a marked clinical concern. And I think this is an important piece. I think in our conversations that we had with the writing group, there are many countries in which a nurse actually is not allowed to take an AED off of the wall and to help a patient on the ward. When we had that conversation, my jaw dropped, right? And I said, what? I mean, nurses, anyone, right? Anyone in the hospital who has been trained in CPR, BLS, I think should have the ability and the skills, right, to be able to do that. But in many places, they actually had to wait for a physician to approve that before they could actually even allow for an AED to be used. Yes, I'm seeing a lot of shaking heads, right? Yes, like what? But it does, I think, give you an idea of some of the challenges, right, that people are facing, and how do you empower somebody, give them the skills, and then say, oh, but you have to go check with someone first before you're allowed to use that device that somebody created for anyone who could use in the community, right? Let's be honest. When we talk about AEDs, we say it would be nice if you had training, but you don't need it, right? It literally walks you through everything to do. So again, this is, I think, one of those cases where we really felt as a group it was really important to empower the folks that were at the bedside. So to me, that bucket of marked clinical concern honestly should probably be about this big, and the other ones would be about this big, right? Because those are really when you have that gut feeling saying, like, my patient doesn't look right. I think that really becomes important, and being able to trigger that and not in oh gosh, now we have to go assess another patient, but wow, great, I'm so glad that we're assessing this patient before they potentially have an arrest. So the next bucket that we talk about is perform. So develop and deploy effective resuscitation response systems, deliver guideline-based resuscitation care, and deliver guideline-based post-resuscitation care. So many of you guys, I think, work on this specifically within your institution. So having hospital-wide resuscitation response systems that are easily and rapidly activated, ensure that high-quality resuscitation team that includes pre-assigned, experienced, and interdisciplinary healthcare professionals. So I worked last weekend in the San Diego VA, and I think in my Saturday shift, I think we had probably about 4 rapid response calls in my 12-hour shift that I was on. And these were different, these weren't step-down units. Most of these were on general wards. And I actually think, to me personally, that is important, right? I think we should be assessing more people so that we're not getting to the code blue response, but really getting to that rapid response team early evaluation response. And I think this is really, again, integral to why having that resuscitation response system in place and having people feel empowered and that you're not making more work for them, you're actually doing the right thing, I think is really a culture change that the VA, I think, has done a really great job with. So delivering guideline-based resuscitation care. As you all know, the Heart Association is the leader in terms of developing CPR guidelines. So we focus on, the essential components of guidelines-based skills for BLS, ALS, and pediatric life support. This includes prompt initiation of high-performance CPR defibrillation and the use of appropriate and cause-directed interventions. Avoid non-recommended interventions and early termination of resuscitation. And I think this was an interesting conversation that we had as a writing group. There's a lot of folks who like to say, oh, well, I read this or I saw this on social media last week. I think we should try this. And we had a lot of conversation about that, which is there's a reason that there's an evidence-based review process and evaluation process that is very rigorous and takes literally years to do. And it's not because we're slow and we're dragging our feet, it's because we want to make sure that before we recommend a practice that it has solid evidence base and it's not just based on a really cool study that was published and got really great social media traction, right? And I think that's an age that we're living in, and that's where we really wanted to be very intentional about this, is that it's got to be something that has had the evidence base to say it should be recommended, and that people shouldn't be having the theory of, well, they're already dead anyways, why don't we try this? We think that's important, right? It's an important piece of why we've gotten to where we have, is that taking the time to make those guidelines and to work through the ILCOR group to make global guidelines is really important. And then the early termination of resuscitation, again, as we talked about lower resource settings, this was actually something that they brought up, which is that in many of their settings, people will not even get to 10 minutes, 15 minutes of resuscitation. They'll kind of walk in and say, well, you know what, they're probably not going to make it anyways. Let's just stop. And so again, thinking about what that means in your context and making sure that folks have the idea that cardiac arrest is a survivable event, right? And not having that idea that it's futile, which I think is something that oftentimes we have to deal with as well. So we are currently developing our 2025 CPR guidelines. So you guys heard it first. You probably heard it a few months ago too as well, but they're coming. We actually work with I'm not sure if folks know this, but we actually work with the AAP, the American Academy of Pediatrics, to jointly produce our pediatric and neonatal guidelines. And then we work with the Red Cross to do our first aid guidelines. And so those first aid guidelines we'll be publishing in this year as well. And then our CPR guidelines will be coming next year. And then our guidelines for the AHA actually serve as the guidelines for the Inter-American Heart Foundation, which is primarily in Latin and South America, the Resuscitation Councils of South Africa, Heart and Stroke Foundation of Canada, and then 100 plus countries, like I had mentioned, use our guidelines through our training centers. And then we have other guidelines, and we work very closely with the European Resuscitation Council, the Australian and New Zealand Committee on Resuscitation, and the Resuscitation Council of Asia to make sure that our guidelines mesh, right, and that we're not contradicting each other. So about 50% of that evidence review comes from ILCOR, which is made of these different member councils, and then the other 50% of our guidelines are actually done by our writing groups, specifically with the AHA, who are reviewing the evidence. So just briefly, ILCOR, I'm sure, have you guys, raise your hand if you've heard of ILCOR. Oh, I love it. Okay, I love this group. Okay, so that's great. So, ILCOR really, I think, has been something that has been around since about, I should say, 1995-ish. It was started actually by the Heart Association, the European Resuscitation Council initially, and then has grown now to 7 different member councils. And the idea is that they help build out the evidence review process, right? So if you think about systematic reviews, meta-analysis, analyzing all of the data, ILCOR will do, like I said, about 50% of our questions, our research questions. They will ask and they will actually answer sort of based on what the evidence shows, what they think their summary of the evidence is. And then based on that, the different resuscitation councils will come up with our own guidelines. And that's based on clinical efficacy, ease of implementation, and then our local systems factors. And so as you can see, that's why the ERC's guidelines may look a little bit different than the AHA's guidelines. About 50% of that work is being done by our writing groups, and we're trying to tailor all of the information that's coming into a North American context, really. Updated guidelines, as I'd mentioned, this was from our 2020 CPR guidelines, and you'll see something similar for 2025. And then delivering guidelines-based post-cardiac arrest care. Again, this is really important after the event to empower multidisciplinary teams to provide guideline-based post-cardiac arrest care throughout and beyond hospitalization, using multiple modalities to inform prognostication, and then considering organ donation when appropriate. So this is actually a paper that we just published this last year that was done in conjunction with the Neurocritical Care Society. Raise your hand if you guys knew about this paper, and it's okay if you didn't. Okay, it's a huge, massive undertaking that we started in 2019 and then had COVID. I don't know if you guys have heard of that pandemic thing that kind of, derailed a few of our writing groups, I'll say, as we all were stuck in the hospitals. But we did just finally, after 4 years of working together with NCS, come up with what I think is a really foundational document to look at the different aspects of post-cardiac arrest care. And so this is just one of the figures from that paper. And again, I've got the link at the bottom. But it's the critical care management of the patient after cardiac arrest and looking at the different organ systems and patient and family-centered care that should be taken into context. So if you guys have a chance to take a look at this, if you can circulate this even with your, and have conversations with your ICU folks, your neurology folks, all of the people that are invested in the post-cardiac arrest care, I think this is a really nice, very detailed, very thorough opportunity to look at what can and should be happening post-cardiac arrest care. And then finally, principles and culture. So implement a culture of excellence in care. And I would say that's what you guys are doing right now. And it's so cool and great to be a part of that here at the Ready Symposium. And then ensuring the well-being of healthcare professionals. So when we talk about that person-centered culture of excellence in care, ensure that there is informed, culturally appropriate communication with patients and family to support them and to understand their goals, values, and preferences. For cardiac arrest survivors, development of post-discharge plans with targeted resources is crucial for recovery and survivorship. And then for families of non-survivors, offering grief and bereavement resources, not just at the time of that person's hospital stay, but knowing that the grief and bereavement process will extend way beyond the hospitalization. So really thinking about what are you doing, not just for the patients, but also for their families and caregivers as well. So this is a case study from Sweden, and this was actually launched by the Swedish Heart and Lung Association. It's in Swedish, so I apologize. But it does actually give you a great idea of some of the things that people are doing around survivorship. So it's a closed Facebook group that's available. There's a website that's available, and it really is just an opportunity for folks to connect, right? So people who have survived, people who have not survived, and then having the ability to connect there. Within the Heart Association, we're also working through our own survivor network to create a cardiac arrest specific kind of place for people to go. And one of the big focuses that you'll see coming up in the next year is actually to create survivor and co-survivor resources. So those will be coming soon. And I hope that you guys will help to really promote that as something that, really I think is an important piece of the post-arrest process, right? So we had a great conversation with some of our survivors and some of our co-survivors, which are the family members of the folks who had the cardiac arrest event. And they asked for things simple as, can you give me a checklist of questions to ask after my loved one has had a cardiac arrest? So how many of you guys have any of those resources currently? I feel like that's important, right? Because I think, again, as we talked about to our co-survivors, so the family members of the person who just had the cardiac arrest event, they said, gosh, I don't even know where to start. my loved one has just had this traumatic event. I'm trying to figure out how to make sure my kids are fed and they have a babysitter. And you're asking me questions, like how am I supposed to proactively know what questions there are, right? And for those of us that are in the medical, profession, it might be a little bit easier, but even then, you think about it, you've just had this horrible situation happen. I don't know if I could think straight. And so just starting to create those resources and have those available to you guys so that you can circulate those and even fill in some of your own resources locally that you might have. Maybe you have a cardiac arrest survivor group that you guys have meet, or you have the ability to fill in, hey, we have cardiac rehab facilities that we contract out with. These are your options. Just being able to have that sort of plan for those co-survivors for the event and immediately post-event, and then having those resources available so they know to ask those questions. My loved one just had a cardiac arrest event. What are my options for cardiac rehab? How many have you guys, I know for my patients, most of them have not we've come up to them and given them those opportunities to ask those questions. I'm not sure if we have done really a great job of really standardizing that and helping them sort of proactively think about what they should be asking us, right? So I think this is hopefully going to be another tool and a way for you guys to also help communicate with your survivors and co-survivors. And then finally, just the last one, and I think this is interesting for a number of reasons. So we had 150 potential things that we could put in these 10 steps, right? So when we asked everybody from our global community to put all of these potential 10 steps that are going to revolutionize resuscitation care, this is one of our top 10. And I think it's important, especially as many, we've all lived through the pandemic, we've all lived through the burnout, right, that has happened, I think for many of us, really having to live through that. And this, I think, is really showcasing how important it is to think about our healthcare professionals. And so there needs to be a holistic focus on the psychological, physical, and spiritual well-being of healthcare professionals. Caring for the care team ensures that treatment of IHCA patients remains at a high quality. So I think all of us have really lived through a traumatic event, right, or multiple traumatic events. If you think about, I think about my, during residency, my second year, I had a 5-year-old child who was a drive-by shooting in Atlanta. And we had a resuscitation that went on for about an hour. And that was almost 20 years ago. And I can still remember that event very clearly, especially because I have a 7 and a 9-year-old now. And so I think really thinking about not just the debrief, right, but also thinking about what does that mean later, right? It's not just right after the event. It's actually thinking about what is that doing to your healthcare professionals over time, psychologically, physically, spiritually, mentally, emotionally. And I think the VA, has a really interesting approach in that we talk about whole health, right? We think about that a lot for our veterans. And I think we talk a lot about that with our own healthcare professionals. I know I've done a couple of whole health courses, but I think really putting it in the context of it's not just after the event. It really is going to be something that needs to probably continue to be conversations 1 month, 6 months, even a year later, for people to continue to process and talk through what they're seeing. So what happens next? So for the ILCOR group, we're actually going into a dissemination and implementation phase. We just received additional grant funding to do this work. So we published, obviously, our work in circulation and resuscitation. We've created this community on ilcor.org/in-hospital cardiac arrest. This is where a lot of the case studies are. We also invite you to put your own case studies in. So for my gentleman from Africa who talked about our tool in the VA, I think it's going to be important that we actually start providing those case studies to others so that they have the ability to really hopefully learn from all the things that we're talking about here. And then we actually have a global IHCA resuscitation academies that'll be launching. And the idea is that we will be going into different countries through our regional councils and putting on IHCA kind of essentially mini ready symposiums. So Lisa, if you could just tell me how you guys did this, that would be fantastic. But really with the idea to bring together folks in a 2 or 3 day in-person meeting to have conversations both to network, but also to bounce ideas off of each other, and then to talk about where strategically do we need to go next in learning from one another. So I'm going to stop there and open it up for questions. I did bring my phone up here because I know there was a few questions that popped up on the app as well, but I'm going to open it up for conversation first, and then if we don't have any conversation, I'll take the questions from here as well. So thoughts, yes? And I hope you guys are also going to be sharing your experiences, right? So these are the 10 steps. I think one of the big things is really, what have you learned? What have you guys focused on? We actually have a needs assessment that you can take as well for your specific facility. If you guys want to see where do we excel, where do we have opportunity to maybe improve, we have that needs assessment put together.
Oh, nice. So first of all, thank you for your presentation. It's amazing. I am a patient safety manager now, but have a big background in emergency medicine and working on some things in our facility as far as like advancing our in-hospital resuscitation rates. My question to you is, I really like that you brought up the well-being of staff, because as you know, in the emergency department and wherever you work, those things stay with you throughout your life. And I feel like after a code, we are in a big hurry to get people back, disseminated back to taking care of other patients, and we have a debrief where they can write down a few things, but it's not really a psychological debrief. So I was just curious what thoughts you had on how to impress the importance of that for the well-being of staff, both immediately and an opportunity for them to maybe, you know, an hour later or a few days later be able to discuss the code and look at the pieces of it that, you know, would allow them to psychologically heal.
Mm-hmm. And I'll talk about this probably from a little bit of personal experience as well too. I think one of the things is just probably keeping that door open. So I think oftentimes people think of a debrief as a one and done kind of event, and like, okay, we talked about what went well in the code, what didn't go well, what are we going to improve, how are we going to make this better for next time? And so we're so focused on the technique, the steps, what, you know, kind of the process. And I think shifting that focus, maybe even at the end of that initial debrief, to talk about, okay, that was great, we have some really great action items, but how do we now shift this conversation to how you feel? And that's hard, I think, for a lot of healthcare professionals, especially I'll say it as an ED doc, right? Like, oh, we're good at this. We do this all the time. It doesn't matter, right? I will say I worked the Aurora Theater shooting. I'm not sure if you guys remember that, about in 2012. I was in the emergency department as one of the attendings that happened that night. And we did, you know, we had 23 patients that came in with horrible gunshot wounds. 22 of them survived. But I remember our debrief was literally that day, that night, at 4 a.m. after we had cleared out the emergency department and sent most people to the OR. And it was like, okay, well, that went well. Great. And then we had like a mental health person that came over to us, I think at the end of my shift at 7 a.m. and said, does anybody want to talk? And everyone said, no, we want to go home, right? We've had a hell of a night. Like, all we want to do is go home and like cry, right, in private. And so I think what we did from that was actually then create, we actually self-created a group of professionals that worked that night that continued to meet weekly, and then actually I hosted a meeting at my house. And we brought everybody together about a month after the event because people weren't sleeping. They weren't eating. They were waking up at night. They were, you know, there were things that were happening in their lives that they couldn't really tie back to that traumatic event until we actually had that conversation, and they said, wow, oh, you're not sleeping either? Huh. Okay, me too, right? And so normalizing those conversations, not just initially after the debrief, but making it an open forum for people to come and talk even like a week later. Because I feel like a lot of us we're so busy doing that by the time you get home and you have a minute to not do is when you actually think, right, about what just happened. Right. So I think that would be one of the things to think about.
Yeah, and I think that's an excellent point, and it doesn't have to be a big mass casualty influx. It can be just that young nurse's first code or that young physician's first code, you know, who, you just kind of get emotionally attached sometimes and you can't really pick or choose the things that impact you the most. And so sustaining their well-being for longevity in the career is also a concern, so they don't burn out. I also had one other question. I don't want to.
Yeah, for sure.
And that was your process for post-cardiac arrest. Mm-hmm. So I feel like we are a little behind cooling patients down, post-resuscitation, like you said, for the organ, health and people that survive that over a period of time. So is there a plan to kind of push that across the VA so that we are more consistent with that?
So I might turn that over to Lisa and Dr. Zhang. I don't know if you guys have comments on that. I can say from the Heart Association perspective, what we want to do is create those tools and create those toolkits for you guys to have available. So including like a mock code, a debriefing toolkit, and then having these like survivor, co-survivor resources that you can kind of just essentially print out, put your hospital's logo on and send out. I mean, that's really the ultimate idea, right? Is that we give you the starting point. You can just tailor it to whatever setting you're working in. I don't know if, Lisa, if there's a specific plan around post-cardiac arrest care and kind of developing tools specifically within the VA. I think we're happy to partner with you guys and think more about it. I think TBD. But I think it's actually something that's interesting because I think we've actually, even at the Heart Association side, we had a survivorship statement that came out a few years back. And that was really a wake-up call for us as an organization to say, we spend so much time on the process and the resuscitation, but we don't spend enough time on the survivors and the non-survivors, right? And the co-survivors, which is the family and caregivers of that person who's had the event. And so I think there's an opportunity there, just by the fact that, again, do you guys already do anything in your own settings right now for patients who've had a cardiac arrest? Not yet, okay. So I put that out there. I think 2 focus areas really for 2025, I know for us, are going to be around the survivorship aspect. And then even we actually added that as a link in the chain of survival in 2020 was survivorship and recovery. And I think we're really trying to build out that. And I think also then thinking about how does that translate out to our healthcare professionals who lived through a traumatic event. No matter if you're doing it for the first time or the 70th time, it doesn't matter. It's still a traumatic event. And how do we process that? So to come, and I think, Lisa, we have an action item. Yeah. So I think there's a question in the back, or other, yeah. Thank you, those are great questions.
I was just mentioning ICU Diaries is actually supported by SCCM and published by Kelly Drumright, who works in our Vanderbilt VA.
Oh, do you mind using the mic, sorry, just so that way everyone can hear you?
Sorry,
Yeah.
ICU Diaries is one of the newer things. The Society of Critical Care Medicine is supporting it, and one of our nurses, Kelly Drumright, in the Vanderbilt VA, published on it along with several others, and they're really seeing a huge difference in the ICU survivorship, and it is used with both family members as well as the patient themselves.
And what, can you tell us a little bit more about what ICU Diaries is?
So it is a mechanism of both the family recording what's going on with the patient on a daily basis, or the nurses also will facilitate. And then as the patient is able more, because now that we have patients surviving, they can have a lot of post-ICU significant issues, and they're actually seeing an improvement in adjustments and decrease in PTSD and different components that they're seeing post-ICU stay, which also includes the resuscitation or arrest patient.
Thank you for sharing. I know we actually have an SCCM liaison for the Emergency Cardiovascular Care Committee that I oversee. So I'm actually going to go to them today and look at that site, because I think that's great. I mean, I think one of the things we hear a lot from our patients is, what do you expect? What is my recovery going to look like? And I think most of us say, it just depends. Everyone's different, right? And I think that's an answer that we say because we don't really talk about it a lot. We don't really necessarily know, and everyone is a little bit different. But there's a real thing about short-term memory loss. There's a real thing about people not necessarily, understanding what's happened to them. And then there's a real, how do you get back to work or back to life, right? Am I going to be the same person? Am I going to be different? How am I going to be different? What is an AICD? Right? Why do I have to have one of these? Should I have one of these? Should I not? I think there's a lot of things that we can probably help people process just by even having other folks' journeys documented. So I think that's a really great resource. Oh, and then we have another question over here too as well. And sir, you have an action item also. I hope you put the ILCOR website down because you have to submit a case study.
Hello. So I work at the Nashville VA, and one better than the diaries is that every Monday at 10 o'clock, patients who survive the ICU can come and discuss things, and the family can come and discuss, the medical conditions that got them there, and maybe a more debriefing about their ICU stay. That's actually an ideal place. I've just realized that we could refer all our our CPR survivors too. So we actually have a mechanism for it right now. I didn't realize that. I've just thought about it. But the Kelly Drumright thing with the thing also has the Monday 10 a.m. family survivorship from ICU. But we could probably add in code survivors.
Is that a national?
Yeah, it's in Nashville, Tennessee. No, it's not a national thing.
Oh, okay. I was going to say, so it's
a local
Nashville.
Nashville VA.
Okay, sorry. I thought you said national. So in the national Nashville VA on Monday mornings. You guys have sort of a family
Yeah.
peer support group, if you will.
Correct. Exactly.
Oh, interesting. Okay.
Actually, that guy, one of our survivors, ended up at the SCCM meeting relating to that whole thing and was a speaker on the stage.
Okay.
He used to come every Monday and discuss his survivorship with the families and say what other things you could, debriefing things that, and support groups were available. And he was like a leader in this thing. He was amazing. He got bored after 2 years. But
Yes. I was going to say, I think that's a really interesting idea. And I think, again, this thing, to me, the thing about the VA that's really great is that we have VISNs, right? And we have different ways in which we collaborate, whether it's nationally or through our VISNs. To me, that seems like actually an interesting idea, even maybe that could be expanded out through the VISN. And it doesn't have to be an unruly number of people. It could actually just be, here's an opportunity on 10 a.m. Monday morning for folks to come and talk, right? And so I think that's actually a really great idea. Put that on the list too as well. You can go ahead and put that in the case study the other case study that you're going to put into as well. So many action items. Thank you for sharing. Yeah. Oh, I think actually, I was going to say, yeah.
Program was after a pediatric cardiac arrest. They noticed the families were just having, obviously they're so emotional, they don't have the ability to, like you're saying, answer those questions for them because they don't even know how to process the event. What they did was they actually made a program so that in the coming weeks they could actually schedule an appointment with the emergency medicine physician, as well as they'd invite the pathologist who did the autopsy. And they had a sit-down meeting together that the family could schedule so that then they'd have that time to process, write down the questions. They knew it was about how they could bring closure to these families by answering the questions. They had an incredible response rate from the program. The other thing I wanted to just share was a peer support program that I also was a part of that was really effective. And what it was we actually trained hundreds of people in a hospital with a 4-hour online training on how to be a peer supporter. And we would finish every single cardiac arrest, every single difficult case, and the team leaders would say, we know this is hard, like you're describing, for everybody, and we even had like QR codes, contact me if you want to talk, and it just had an easier mechanism to connect people who wanted that opportunity for peer support by doing those QR codes. We were seeing literally hundreds then of people who wanted to be a part of this and have those conversations. And it took about a year to get to that point where we would have over 100 requests a month. But it really was about training enough people. And I think sometimes when you don't have that training, those conversations are hard. Like, I don't want to say, like, are you having a hard time?
Right.
It's hard. But if you give people those training tools and you do it well, I think you can empower them to make those connections.
Because sometimes, especially younger staff, people don't know what PTSD is.
Right.
Like we're talking about not sleeping. They don't recognize, I'm sorry, I just wanted to say I love that because people don't recognize those signs and symptoms. So the training is great because it can be really suffering privately and not really realize what's going on. So I love that. Yeah, thank you.
And is that at a VA facility? It wasn't. Oh, nice. Okay. I think, again, it'd be interesting to think through. There's, mental health first aid, I know is like an actual thing that, folks can take. But I do wonder if there's any VA courses specific to peer support. I'm asking this question, actually, because I don't know the answer, for healthcare professionals to take. I don't know if anyone has any ideas about that. But I do think that's a really important thing because it's not just me coming up to you as a team leader, and you may feel like, oh, I don't want to say, right? Like, I don't want to tell you that I'm not doing okay, right? So sometimes it is just having that like kind of anonymous QR code. You can connect with somebody who maybe you don't actually know that well, which actually sometimes can make it easier to chat. And then there's other people who say, actually, I want to know the person I'm chatting with. So I think having those options are really important. So I think that's an interesting idea as well. So many great ideas, you guys. This is awesome. Yeah.
Sorry. My nephew died at the age of 37 after 2 resuscitation events. After the first one, shortly thereafter that, he started having some neurological deficits. It was very evident to me. And then he rearrested and he was resuscitated for a long period of time. So my question is, if we are looking at avoiding prolonged resuscitation or avoiding termination of resuscitation early, from the perspective of a family member, if he survived the second resuscitation, I know he was going to be a vegetable, and we will bring him home a vegetable.
Yeah.
And it would have broken our hearts tremendously. So at some point, we have to make that critical decision. Are we trying to create more survivors versus survivors with your neurological intact condition?
I think that's a really important point, and I think that's really where those conversations are they're not even conversations that you have, this is what I want in the community when I'm young and healthy, and this is what I want you to do everything, but it's those constant kind of conversations with the family to assess what they think is best, right? Because that situation can also change within a hospitalization, right? In terms of, yes, I want everything done, or maybe we don't want everything done because we know that the outcome will not be good. And I think it's really important to keep that perspective as well. And I think one of the things that we were talking about with the post-cardiac arrest care also was making sure that people, for example, if you're doing targeted temperature management, at 24 hours weren't trying to do a neuroprognostication and say, yeah, this patient, hasn't woken up yet. Well, they may not wake up for 72 hours, right? And so making sure that those conversations are happening in the interval that's appropriate for it. But I think also, to your point, it's also making sure that to even start, the resuscitation is congruent with the family wishes, right? I think that's a huge part of that.
Hi, I just wanted to ask a question about, you talked about guideline-based care, and I understand lots of studies go out on social media, but I think TTM was one of those issues where, we're reading the evidence and we're looking at the fact that maybe we shouldn't be cooling these patients down, and the guidelines were still recommending it. And there was from the physician group, we're saying, hey, we probably shouldn't be doing this, but then, admin is looking at the guidelines and saying, well, that's what the guidelines say to do. So how does the group, first of all, thank you for all the work you guys are doing. And I guess, what's the plan to speed up the process when, we know that maybe the guidelines are lagging a little bit? What's the plan for that?
So for TTM too, right, when that trial first came out, I think actually ILCOR put out some consensus on science around it, which basically said, think more about avoidance of fever, right, and more about targeted temperature management, keeping them normothermic, if you will. And so we actually put out our advanced life support focused update, which actually was published. I think we were trying, this gets to the whole idea of how long it takes. The group got together literally the day that study published. And getting consensus from the group to actually put out a focused update took about 3 months. And that was just because everyone was sort of, one of the things I think with the TTM2 trial was that they also were subgroups of people where there probably is some benefit to having targeted temperature management. And that was actually where a lot of the conversation within the writing group focused, was that, do we want to have a blanket statement that says nobody needs it anymore? Or do we want to acknowledge the fact that there are subgroups that are likely to benefit, but we need more data, right, to know exactly which of those subgroups would benefit most? And so I want to say we want to continue to speed up the process, and I think part of it is just getting people in the room to have those very frank conversations to say, here's what the evidence is. And I'll put something else out there, double defibrillation, right, dual sequential defibrillation, right? I don't know if any of you guys get Doximity or Medscape. I think Australia and New Zealand, I think it is, just changed all their guidelines to say that everybody can get double sequential now in the field. We hosted a summit actually with the FDA and Sheldon Chesky's and all of the kind of folks from both sides of the platform, if you will, around DSD, and said, what do you guys think? And so trying to get to consensus with the experts in the room who actually published the trials, plus all the other people who say, well, actually, did you think about this, this, and this, takes a little bit of time, and I think we're trying to speed up that process as much as we can. And what we're trying to do also to be responsive is to put out podcasts where we talk about the evidence, right? So it may be that the AHA doesn't have a focused update out yet, but can we at least start addressing what are the good and the bad, right, of these studies? And I think that's really where people hopefully can focus, and I think it's hard, right? In those 9 months that we didn't have a focused update that came out, what do we do? Do we still do TTM? Do we not? And so I think, again, that's something that we're still continuing to work on. But that is the process, if that helps to kind of talk about why we have or have not addressed it.
Thank you.
Yeah. But if you want to be a part of that process, let me know. Feel free. My contact info is right here. So we're always looking for volunteers, and we want volunteers that are coming from all different types of disciplines, right, too, as well. I put that out there. It's really important to that conversation.
I think it's on.
And at least I think we still have, if I'm looking at this correctly, do we still have about 5 minutes or so more for questions? Okay. Yes. Oh, actually, we can go there. Yeah.
Where can I find the facility screening assessment?
Oh, the needs assessment?
Uh-huh.
Yes, I think had a slide on that. Let me just make sure. Oh, let's see here. Sorry. There is a QR code, and so I'll make sure that I'll put that on the app for everybody so that you guys have the website.
Thank you.
And the needs assessment really was built out of the idea of looking at the 10 steps and really kind of doing a formal assessment of your own facility to where should we be focusing. So, sorry, I can't go back. I apologize. Okay. All right. This may be it, if you want to try that QR code and see. Or it may take you to the ILCOR website. I'm not sure. We had so many QR codes in this presentation, I couldn't remember which one I put in. Sorry. But if not, I'll put it on the app so you guys have it, along with the ILCOR website too.
Sorry, I just want to remind everyone that most hospitals should have employee assistance programs that should assist with these untoward events that patients, staff have, and they can get help through EAP. And EAP put out annual and semi-annual emails to people if they're not feeling well or they're stressed by their job, they could contact EAP in a non-punitive manner, right? Just to remind everyone, the VA system has an employees assistance program for people who are distressed by their job.
Thank you. That's a great point. I think it's confidential too, which I think is important for folks, so they're not going to be penalized, right, for having that. All right. There was only one other question, I think, from the audience that I wanted to make sure I addressed. And this might be something. So fast response is always best. What about mouth-to-mouth when no ambu bag? Was a question that popped up. What was that? Bye-bye. So I think it's hard, right? I don't think that how many of you, and this is a safe place, we're not telling your employers, how many of you would do mouth-to-mouth?
No.
I would wait. I think and if you think about, the thing about CAB, right, is that compressions, 2 minutes of compressions, right? So getting your hands on the chest for 2 minutes and starting those 2 minutes, I'm hopeful in a medical setting that you will have 2 minutes at least to get an ambu bag. And so I will say, and I think the pandemic has changed a lot of things. You saw a lot of our COVID guidance obviously was all about, kind of making sure that the healthcare professionals stay as well. I think that guidance is still really important, right? I don't think you can do your job if you're doing mouth-to-mouth on a patient, and I would hope that most of us have a crash cart somewhere around that within 2 minutes we could get an ambu bag. All right, and then the last one I think was...
There's a question in the audience.
Oh, sure. Yeah. Sorry. Go ahead.
My question relates to artificial intelligence. So as AEDs give us some guidance, is there any talks about artificial intelligence with guiding our code response and helping us perform better?
So there are products out there that are trying to, I think, work on this specifically. So sort of based on end-tidal CO2, based on compression depth, presenting rhythm, next rhythm at the pulse check, if you will. So I think there's some thoughts around, and there's some products that are sort of in the innovation space to do that. But I don't know that they've come to market yet. I know we just know about them as a heart association peripherally because we get approached by a lot of different folks with a lot of great ideas. But I think that is the wave of the future. So really like resuscitation guided resuscitation, right? I mean, right now we have a lot of sort of do this at 2 minutes, do this, do this, do this, and our patients don't necessarily follow that algorithm. So I think that's going to be something that we're seeing more and more of as we start to figure out how to use AI in real life as well. Yeah. Mm-hmm.
The Lucas device coming to inpatient, since it seems like it gives the correct depth, the correct rate, and it takes away the human error of compressions. What are the thoughts on that?
So we actually do have some guidance on that. We had guidance both for the COVID-19 guidelines and then also for the 2020 guidelines. And I think what we say is that it really depends, right? Because I think there's also, the Lucas is a great device, but Heart Association does not actually say anything about any devices. We're device agnostic, number one. But there are also challenges to that device, right? Where there's delays in care because people are trying to figure out how to get the device on and, is it even appropriate to get it on? Is it going to be the right depth? If you're a frail 90-year-old, is it going to need different amounts of pressure, right, to get to at least 2 inches versus somebody who's 400 pounds, right? So I think there's some other kind of caveats to that. And then the 400-pound veteran wouldn't actually be able to have a Lucas device put on them because it's likely that they wouldn't be able to get all the way around. So I think the answer is it really depends on your facility and probably your local champions about what they think is sort of the right thing or not. I think the big thing from the Heart Association perspective is make sure you get the hands on the chest, right? So however that's done is important, but we also know that the nice thing about having a human do these skills, and that's why we have you guys do the RQI thing every 3 months, is that it's important to have that ability to tailor it to the patient as well, right? All right. Any other last questions? These are great questions, by the way, and I'll be available all day today as well if you guys want to come and say hello. And I think that gentleman back there just volunteered for a writing group, is that right? Awesome. So thank you guys, and thank you for the opportunity to be here. This is such a great place.